It is now my pleasure to turn today's program over to Alicia Jewett. Alicia, you may begin.
Thank you very much. Hello, everyone, and thank you for joining us today. I am Alicia Jewett. I would like to welcome you to today's learning event, the Overview of Care Delivery Model. Next slide. During this webinar, you'll learn about the Comprehensive Primary Care Plus Care Delivery Model and the high-value changes attributed to improving the experience of care for patients and clinicians alike, which is the goal of this program. So during this webinar, we will describe the key drivers of the CPC Plus Care Delivery Model and how they relate to one another. We'll introduce two panelists that will throughout the webinar share their experiences in CPC Classic and in transforming care delivery. We will highlight the care management primary care function, focusing on that single function to guide you through using the change package, which is a new document we'll be talking about today, the requirements, and the roadmap to make changes in care delivery. Toward the end of the event, we will remind you of the schedule of upcoming learning events, which we also share in the weekly CPC Plus newsletter. And as time allows at the end of the webinar, we will answer your questions related to care delivery that you post to the chat throughout the event. To begin, I want to turn it over to Dr. Laura Sessoms, Director of the Division of Advanced Primary Care at the CMS Innovation Center, who will walk us through the CPC Plus driver diagram. Dr. Sessoms?
Great, thanks, Alicia. During last week's webinar, we discussed some basic information about practice participation in CPC Plus, and we had two CPC Classic practices who discussed what it's like to participate in a CMS model. Today we're going to move further into the work of CPC Plus, and we'll review some of the documents we've given you to help you understand more fully the overall design of the model and what together we're trying to accomplish. Most importantly, the point of today's webinar is to help you start thinking about, really concretely, how to do the work of the model in your practice and how to make sure that the work that you do in CPC Plus is focused on the aims of the model. We have two CPC Classic practices joining us today to give us their invaluable insights on how they've done some of this work in their own practices. On the screen now is what we call the logic model or driver diagram for CPC Plus. In one single picture, it gives you the overall model design. I promise you'll get used to seeing this. It definitely helps me think logically about the work, and I hope the same is true for you. So let's walk through it briefly now. As you see at the center are the patients and the families we care for and our collective aim of better care, smarter spending, and healthier people. On the lower half of the diagram are what we think practices must have to transform care delivery. Enhanced accountable payments, shown in green, optimal use of health IT in orange, and continuous improvement delivered by data in burgundy. This lower half supports the top half of the driver diagram, the 5 primary care functions in blue that are the work of practices in this model. And we believe that all of this work must occur in the setting of multi-payer aligned payment reform shown in the outer purple rim. Now I'm going to go back to those blue 5 primary care functions, which describe the care delivery work in CPC Plus. These 5 functions are what support the delivery of comprehensive primary care at the practice level, and they are, from left to right, attention to both access and continuity, provision of targeted care management, the pursuit of comprehensiveness in primary care, and the seamless coordination with resources outside of primary care, including clinical ones and community-based resources, then engagement of patients and families in their own care and in the process of improving that care, and last but not least, strategies for planned, proactive care and improvement in the health of populations and the patients cared for by the CPC Plus practices. So this is obviously high level, and there's a lot more detail to all of this that's necessary to understand so that you can do the work in CPC Plus. So to help guide your work in these 5 functions, there are 3 other resources you have now to work with. The first of these are the CPC Plus care delivery requirements, which of course you've already seen. Each year there will be requirements for participation in CPC Plus, and these requirements are tied directly to the delivery of the 5 comprehensive primary care functions. In CPC Classic, we call these milestones. In CPC Plus, we call them requirements. As a condition of participation, your practice has agreed to meet the year 1 requirements, and in the years to come, you will be given the opportunity each year to review the requirements for the coming year. The second of these 2 resources is the CPC Plus Practice Roadmap. The roadmap is found in the Phase 1 implementation guide you got in December. The roadmap is a suggestion about how your practice might order the work of care delivery transformation to meet the CPC Plus care delivery requirements during 2017. Of course, your particular practice may be further ahead on the work of 1 or more of the requirements and may be behind on another. So you will want to adjust the timeline and work of the roadmap to the individual circumstances of your practice and the practice population so that you can meet the CPC Plus requirements. Finally, the third of these resources is the CPC Plus Change Package. This document is new. The change package is available today for download for the first time during today's webinar and will also be distributed in tomorrow's newsletter on the Plus side. This is critical information that goes beyond the CPC Plus practice requirements. It has more details, we call them change tactics, than the CPC Plus requirements. While the requirements are required and can provide a wonderful guide into the work of comprehensive primary care, I assure you that if your goal is only to meet the requirements of participation, you will not fully succeed in this model. At the center of this work is our aim: better care, smarter spending, and healthier people. And this aim has to be your guide as you do and then build on the CPC Plus requirements. So together, the CPC Plus practice requirements, the practice roadmap, and the change package are all critical guides to the work of CPC Plus that we will do together, learning from and with each other along the way. Alicia?
Thank you, Dr. Sessoms. We appreciate the helpful overview and the background on the CPC Plus care delivery diagram. It's really nice to kind of put everything in context. We'll continue now discussing this throughout the webinar, but first we want to dive a little bit deeper into the diagram and the model. And to do that, we will have practice representatives sharing. So Amy, will you introduce our 2 representatives that are here with us today?
Absolutely. Thanks, Alicia. This is Amy Gibson. I'm so happy to be back with you again today. And we've got 2 more outstanding practices who've agreed to share some of their successes, some of their recommendations and ideas for you. I think you're going to be really pleased with what you have to hear from them. We'll be hearing from them throughout the webinar. They're also generous enough to stay on at the end and give us some time to answer some of your questions. But I did want to take a few minutes to just let them get a chance to introduce themselves to you. So Angie, why don't we go ahead and start with you. We've got Angie Hughes-Walker from Dr. Randy Walker's Family Practice and Allergy Clinic. Do you want to just take a few minutes to introduce yourself and your practice, and then just tell us a little bit about what you're excited about coming into CPC Plus?
Certainly. As she said, my name is Angie Walker. I'm also a little bit related to Dr. Walker. Dr. Walker is an independent practitioner. Of recent, we now have 2 nurse practitioners. First opened our practice in July of 2003, so we're coming up on 14 years that we're pretty excited about. We have an impaneled patient load of 5,900, and by that it means we look back for 2 years to see who we've provided care for, and that's our impaneled patient. We use eClinicalWorks. During this, we had a little bit of we did a rip and replace in August of 2014 to eClinicalWorks, and pretty happy with them at that point. Some of the things that I like about CPC Plus is it's kind of it's a building block. So the things that we learned in Classic are there to propel us to keep making changes, keep coming up with ideas, keep doing things that result for the betterment of our patients. And so I'm pretty excited that it was expanded, and we're just happy that we were picked to join. So.
Fantastic. Thanks, Angie. Let's move on to Dr. Cindy Chan. Dr. Chan, can you introduce yourself? Tell us a little bit about your practice and what you're excited about moving into CPC Plus.
Yes, good afternoon. My name is Cindy Chan, and I'm the lead physician for CPC Plus at an internal medicine practice in Schenectady, New York. We are one of 31 sites in Capital Care Medical Group, and we're located in the Capital District in New York State. My practice has 3 physicians and 2 nurse practitioners, making up 4.5 FTEs. And there are 6,500 patients attributed to our practice, and we use Allscripts as our EHR platform. When we first engaged in CPC Classic, we didn't know what to expect. Like all clinicians, we set our goals on improving patient care while acknowledging the need to reduce healthcare costs. So guided by the milestones of CPC Classic, we made gains in assessing the patient experience by creating a patient family advisory council. We expanded patient access by providing home visits for our housebound patients. We dedicated resources and specific workflows to close our gaps in care. We have an on-site case manager, social workers, and pharmacists, and developed tools to engage our patients in their own care. And these are just some of the projects that we've initiated as a result of our participation. So our motivation to continue with CPC Plus are the same goals that we set out to achieve: provide better patient care by enhancing the patient experience and improving patient population health while trying to reduce costs. We're excited to build and fine-tune the processes that we developed, and we're really excited to move forward with the new requirement of behavioral health services at our office.
Fantastic. Thanks so much. Well, again, we'll be talking with you throughout the webinar, but now I'm going to ask Alicia to start walking us through the major components of this model. Alicia?
Thank you, Amy, Angie, and Dr. Chan. It'll be great to hear more from all of you as we take a closer look at each of these functions and actually apply it to what's happening in practices. So Dr. Sessoms gave us a great overview of the driver diagram and the care delivery model and how it represents comprehensive care. And now we want to take it a deeper dive into the comprehensive primary care functions, which, as you heard, are foundational to CPC Plus. I'll provide an overview of each of the 5 primary care functions, throughout which our practice representatives will share their examples. After we go through each of the functions, we'll focus in on one of the 5 functions, care management, using it as an example to help deepen your understanding of how the model works and to drive down into some of those resources that are available that Dr. Sessoms mentioned at the beginning. So function 1 is access and continuity, and this is really about effective primary care built on a trusting, continuous relationship between patients, caregivers, and the team of professionals who provide care for them. Expanding access at the primary care team is vital, whether through expanded hours or developing alternatives to traditional office visits like non-face-to-face interactions. Ensuring that patients have timely access to the care team matters. Timely access and continuity enhances the relationship with patients and families, and it increases the likelihood that the patient will get the right care at the right time and potentially avoid costly, urgent, and emergent care. Let's hear from Amy in our practices.
Yeah, Angie, can you give us an example or pick one thing that really helped your practice improve access during CPC Classic?
So we sat down and looked at it early on. We knew coming into the program that we had an issue. Dr. Walker was just one person. It's hard to spread him around. And a lot of times, like a lot of physicians, he feels like he's spread thin. And so one of the things that we knew we were going to have to do was add another practitioner, and we weren't sure about whether that would be a mid-level or another doctor. And so late in 2012, we added a nurse practitioner. And so then in 2013, we made all of our steps are very incremental and measured. And so in 2013, we worked about staggering lunches so that Dr. Walker took his lunch, but while he was gone, the nurse practitioner was still here. And of course, when she took her lunch, he was here. So that gave patients continual access to the office all day long. Now, in 2014, we added, we pulled that nurse practitioner to coming in at 7 a.m., and so her shift went from 7 a.m. to, and I'm not sure exactly when, if it would be 3 or 4, but it gave that early morning access. And I'll be honest, this one I was a little bit concerned about because I thought, who goes to the doctor outside of 9 to 5? Well, turns out a lot of people do. You know, you have those individuals who can't miss work, those kids who can't miss school, and so those time slots quickly filled up. beyond our imagination. And so in 2015, we then added an after-hours service line to the clinic so that if you called after hours, you could actually reach someone from the clinic. Then moving into 2016, we again saw that we were having an issue with access. And so what we decided to do then was we added another nurse practitioner to the team and split their shifts up. So our clinic is now open from 7 a.m. to 7 p.m. Monday through Saturday. And the way they do that is I have one nurse practitioner that works 7 to 7 Monday, Tuesday, Wednesday. And then I have another nurse practitioner that works Thursday, Friday, Saturday, 7 to 7. And with that one, I've also been very pleasantly surprised. We had a little bit of a lag on Saturdays, but what we did was we also dedicated that practitioner to doing home visits. And so now we have an allotted place in the schedule in which she runs out and she'll do home visits on our patients that are homebound. The other thing that we just added moving into 2017 is we actually added a patient advocate. And so I'm very ecstatic about that position because, as you know, sometimes if you don't work here, it's very hard to navigate where you need to go and who you need to talk to about your problem. And so with that patient advocate position, we're advertising, if you're unsure, ask for this person so that she can help navigate the system. She can also identify those patients who are high risk and maybe having issues, and she has free reign of the schedule. And so if she sees that something's happening with this person, then we're all hands on deck. I mean, it doesn't matter how far we're overbooked, that person's coming in. And so those are just some of the slow and incremental changes that we made. And so I'm pretty excited about Plus because we've got some other stuff that we're doing. So
those are fantastic examples, and I love the spectrum that you gave because it can be very daunting for practices to start to bring on more staff. But I love that you talked about how even just switching a few schedules around, bringing someone in early, crossing over for lunches, those are things that aren't going to be, you won't have to require a huge investment to do. So I love that you guys took this incremental approach.
It also allowed us to move to an alternative schedule for our employees. And so, again, as we all know, healthcare seems to be getting a little bit harder, and I don't think that it should be. And so we wanted all of our employees to at least have one day off extra a week so that they weren't utilizing vacation, they weren't utilizing sick days. And so that has, as far as invigorated staff, I think that's been a real, wind in our sails. Our employees really seem to enjoy that.
That's brilliant. You get 2 out of 1. You improve access for your patients, and you also improve the joy of practice for your staff. So kudos to you. So Alicia, let's move into the next one, care management.
So the second function is care management. Care management for high-risk, high-need patients is really a hallmark of comprehensive primary care. Within this function, practices are asked to identify their high-risk patients and high-need patients and provide care management support to the identified population in one of 2 ways. The first is systematically risk stratifying your populations to identify the high-risk patients most likely to benefit from targeted, proactive, relationship-based care management. This kind of care management is called longitudinal care management. The second kind of care management is called episodic care management. This care management approach involves identifying patients based on event triggers, such as transitions of care to different settings or new diagnoses of major illnesses, and providing short-term care management regardless of risk status. Practices are asked to provide both longitudinal care and episodic care management in your practices as part of your CPC work, CPC Plus work, targeting your care management resources in both ways to best improve outcomes for your identified patients. You can guide your care management efforts by analyzing internal monitoring data and payer data, by using care plans that are patient-focused and goal-oriented, and by providing interventions and support that's congruent with patient choices and values. Amy, let's hear again from our practices on this.
Great. Dr. Chan, let's pitch it over to you for this particular function. I know your practice has done a lot to integrate care management services. Can you talk a little bit about how you got started and then, as Angie described, how you continued to grow and improve on those care management services?
Sure. I can talk about both the longitudinal and the episodic care because the processes for both are a little bit different. As I mentioned earlier, we're one of 31 sites in Capital Care, and our group was fortunate enough to have 10 sites participate in CPC Classic. So we have an excellent central business office and a dedicated quality team. So with their help, the 10 sites were able to develop a unified approach to risk stratification, and we were able to share resources across the organization. To risk stratify our patients, we looked at the tools that were available at large, and of the tools we reviewed, we found that the AAFP risk stratification tool was the best one for us, and we modified it to suit everyone's diverse needs. And we named it after the developer, the Matthijs method. We gradually implemented risk stratification by targeting patients at the time of their visit, and at patients' visits, we were able to identify those patients with fewer social resources and refer them for case management. And then through risk stratification, we could identify our highest risk patients who carried a risk score of 4 out of 4 and automatically have them referred to case management. Our implementation of case management to capture episodic care, that's been a constant process of refinement. To effectively identify patients needing our episodic care, we first needed to refine our transition of care tracking process. In July of 2013, we decided to dedicate an LPN to the transition of care from acute hospitalizations and ER visits. One of our many responsibilities was to identify those patients who were in need of case management. Our goal in focusing on this transition process was to reduce 30-day readmission rates and reduce utilization. Our efforts were not without results. We could see from data provided by CMMS that we were reducing admission and readmission rates, but unfortunately not cost. So we created a forum that met 1 to 2 times a month to focus on those patients with the highest risk and highest utilization to see whether there were other resources necessary to support their care. We engaged case management, used home visits and pharmacy consultation as needed, and even with this focused response, we couldn't reduce utilization. So most recently, we started a new pilot to see whether having our case manager start the transition of care process earlier while patients were still in the hospital improved outcomes. And the data on that is still pending.
I love that example, especially how you talked about making those changes based on the data and really looking for solutions. So sometimes it's not an easy answer right out of the gate, and you think you've done all the things that you need to do, but there's always tweaks and ways that you need to really evaluate what's happening with your patient population, and sometimes the answer doesn't come readily. But I love that you're clearly not discouraged, and you're continuing to try and refine your services based on the data that you're getting in. So I think that's a perfect example. Alicia, let's talk about function 3, comprehensiveness and coordination.
All right, continuing on. Comprehensiveness in the primary care setting refers to the aim of practices to meet the majority of its patient population's health goals. It encompasses medical, behavioral, and health-related social needs. Comprehensive care is associated with lower overall utilization and costs, less fragmented care, and better health outcomes. This idea of comprehensiveness adds both breadth and depth to the delivery of primary care services. It builds on the element of the patient-care team relationship, which is at the heart of effective primary care. Under the umbrella of this function, you will increase the comprehensiveness of care based on the needs of your patient population. Strategies to achieve comprehensiveness involve using analytics to identify needs at a population level, prioritizing strategies for meeting key needs of your patients, and working as a team. For some aspects of care, you may best achieve comprehensiveness by ensuring patients receive services at your practice if they're offered there, rather than going somewhere else, and also by adding additional services within the practice that might have previously required a referral. There are, of course, going to be services that are best obtained outside of the primary care practice as well. For those services, practices can support coordination, co-management with specialists, and provide linkages to community and social services. We know that as primary care practices, you really are the hub of care for your patients. You play a central role in helping patients and caregivers navigate and coordinate care. One of the focuses of this function is on outreach and support to patients following hospital and ED discharges and during transitions in and out of post-acute care facilities and specialty care. This work involves building the capability and network of services within your medical neighborhood and community to improve patient care. One of the goals of this function is to understand where your patients receive care, both inside your organization and systems and outside, and organizing your practice to deliver and coordinate care in a way that best achieves positive outcomes for your patients.
Thanks so much, Alicia. And let's head back over to you. As Alicia described, there are a lot of components that go into effective coordination. Can you describe for us just one way, maybe the one aspect that you're most proud of, the way that your practice has improved coordination of care for your patients?
Certainly. And a lot of times when you're studying these things, they will actually jump back and forth over the different drivers or the different functions. So
right.
We found we were having issues as far as getting our transitional care patients into the clinic and getting them in a timely manner. Well, we were getting them in between 7 and 10 days, but there was a 7 to 10 day window that they were just kind of there. And so what we did is we took our 2 care coordinators, and they would take turns calling our local hospital to see if we had a admit, and if we did, they would go over with a copy of their last office visit, a copy of their medications, and then a copy of their specialist that they use. They'd also work hard to make sure that the patient before discharge understood why I wound up in the hospital, what needed to happen, and the changes that were being made to medications. And so those transitional care nurses also had the schedule at their disposal. And so if they really felt like that patient could not wait 7 to 10 days, then they're going to stick them on that schedule wherever they need to be. One of the things that we added this year, or we're in the kind of testing phases of it, is moving some of that to our care coordination transition of care RN, who's also helping out with some of the home visits, because sometimes you only have that block of window that you can see those home visits, but sometimes maybe that provider wants somebody to just put an eye on them. Sometimes that's all they need is someone to go out, look, and make sure everything's going okay, reassure that patient, and then sometimes you can bump those visits back. So that probably is my favorite part of care coordination, because you have so many patients who just don't understand what happened. They don't understand what happened. They don't understand the medication changes, and those things result in additional issues as far as hospitalizations and what have you.
I love that. And I would ask, do you feel like it's changed the way your practice interacts with the hospital staff and other providers in your community? Can you maybe talk a little bit about maybe some of the impact on those relationships?
I think initially it was a little bit of an issue. But I think once we sat down and chit-chatted about what we were trying to see happen, we both wanted the same outcome. We were both looking at those internal measures to see how we could reduce it, and so I think it made just a natural fit for us.
Yeah, I think so much of it that starts to really change, and it can sometimes be intimidating too. When people are kind of heads down the sand sometimes, they're doing their job best they can, and it's really hard to think about how can we collaborate and work with people outside our organization. So stellar job there.
Well, and you have to remember, your patients don't just touch you; they touch everybody in your healthcare community. So it's very important to have those relationships.
Right. It is really hard for patients and families to understand why everyone's not working together when they're not.
Why everybody doesn't know why what they're able to do.
Exactly. Perfect. All right, Alicia, we've gotten to my favorite function, patient and caregiver engagement. Tell us a little bit more about this one.
Amy, patient and caregiver engagement, function 4, is a favorite of CPC Plus faculty and practices alike. Throughout the other functions, we've kind of indirectly discussed various ways of engaging patients and caregivers in their care through access and care management and other areas. But like many of the functions, this one certainly is complementary to the other areas. One exciting area of this 4th function is that practices will organize a patient and family advisory council. It'll help you understand the perspectives of patients and caregivers on the organization and delivery of care, as well as ongoing transformation through CPC Plus. You will use the recommendations from your patient family advisor council to help improve patient care and ensure continued patient-centeredness. Optimal care and health outcomes really do require patient and caregiver engagement in the management of their own care, but also in the design and improvement of care delivery. Let's find out how our practices have done this.
Thanks, Alicia. Yeah, so Dr. Chan, let's go back to you. I know you have a very active patient and family advisory council. I know for a lot of practices I've talked to, this can be a kind of scary thing to do. I'm guessing you didn't get trained during your medical training on how to convene a patient and family advisory council. Can you talk a little bit why your practice thought this was important, they wanted to do this, and how you're now partnering with patients to improve care for the practice?
Absolutely. To be honest, this milestone was what engaged my staff the most. During CPC Classic, we had the option to convene a patient and family advisory council or conduct surveys to evaluate the patient experience. And we opted to convene a PFAC due to the mediocre response rates to surveys we experienced in the past. Little did we foresee the value in implementing our council back at the start of CPC Classic in early 2012. Implementing a PFAC was particularly challenging because, as you mentioned, we really had no idea what it was. So we researched the topic and figured it out from the literature that was available, and we took the elements necessary to successfully implement a PFAC, including council size and frequency and location of meetings. And armed with this information, we went about selecting patients to invite to serve on our PFAC through recommendations of our staff and our clinicians. On retrospect, the selection of our patients has been the key to our success. From those patients we invited, 10 patients were able to commit to the council, and we sent them a simple survey, and their responses sent the agenda for our first meeting. During that first meeting, we outlined the expectations of being a member of the council and laid out ground rules for engagement. Since that first meeting, our PFAC has had a key role in many of the changes that have occurred at our practice. They helped us out with simple things like assessing our office through patient eyes and identifying areas that were just gross. Our exam tables were old, and although they passed our yearly OSHA inspections, to them they were an eyesore and looked unhygienic. So it was clear it was time to replace them. They helped us, obviously, with more substantive decisions, though, like how best to implement self-management support tools and make sure they were at an appropriate literacy level, and how to expand our access to patients by expanding our phone hours, how to engage our elderly patients on the portal. Needless to say, they shared our enthusiasm about offering home visits to our most disabled patients. It's been a learning experience to see our practice through our patients' eyes, and equally important, they've come to understand our daily trials and tribulations better. And over time, through our collaboration, they've really become ambassadors of our practice in the community.
I think that's phenomenal. And the fact that you have now worked together long enough, you trust each other, you're sharing more information back and forth, that on both sides you can really appreciate and understand each other's perspectives better. But I think you brought out a really critical point in talking about the role of the patients in seeing the office through their eyes. We often can't see the things that they see, and whether it's because they're sitting in the waiting room and the clinicians are not, or things that they notice in the exam room. I think that sometimes they sound like small changes, but they can make a big impact for the practice and the way that the patients view the practice. So I think that's incredible. All right, Alicia, Function 5, Plan Care and Population Health.
So the Plan Care and Population Health function is really about organizing your care delivery to meet the needs of your entire population. Using team-based care will help you identify opportunities for preventive care so you can be proactive and offer timely and appropriate care, and also be consistent in delivering evidence-based management of chronic conditions. Through the Plan Care and Population Health activities, you will improve overall population health through the use of evidence-based protocols and team-based care, identification of care gaps at the population level, as well as measure and act on the quality of care at both the practice level and the panel level. Let's drill down a little deeper with a practice example.
Yeah, Angie, as Alicia described, to effectively manage your patient population, data is critical. Can you describe how you've used data in your practice to improve the care for your patients?
Yes. one of my favorite stories of Dr. Walker, and it's probably not his favorite story, but we actually started this journey about 4 years before CPCI and the Arkansas Chronic Illness Collaborative. We were asked to take part in a pilot in which we manage our diabetic patient population. And so I'm bored, so I immediately signed us up, and I'm thinking this is going to be so much fun. And so you had to have a minimum of 100 patients. And, of course, I tell Dr. Walker, and he's like, no, we don't have 100. We don't have anywhere close to 100, and all mine are in control. And so I went back to my office, and I thought, well, I'm just going to run the numbers anyway, because this was my first delve into data. And so I run those numbers, and we didn't have 100. We had 250. And of those 250, about 50% were not in control. And so what I did was I went back to Dr. Walker's office, and I said, well, do you want to hear how bad you suck now or on a conference call? And I think that was a very big eye-opener for him as well, that, the numbers just don't lie. And at that point, I was just addicted to data. It was kind of an eye-opener in why would you make any decision about your business if you didn't have numbers in front of you. And so from then on, I run numbers on everything. My staff, they've gotten to where they just roll their eyes. But the numbers don't lie. More recently, we've noticed that we moved from 250 diabetics to about 368. And, of course, 28% of those are now the ones that are considered out of control. And so by knowing that information, we can target that 28%. And so within the first year or second year of CPCI, we hired a dietitian because we knew we needed to target that group of patients that was out of control. We had tried to control that through our ACT collaborative with different measures, wasn't working, so of course with just foundational information, we're building on that. And so I really think a lot of the success with that, it's hers. I mean, it's hers to celebrate because she works hard at keeping in contact with those patients in between visits, helping make decisions about their medications, when to test, when not to test. And so I think just that little bit right there just had me going. And so now our office, we just don't make a decision without data.
That's exactly what needs to happen. And I think, as you pointed out, even though it was kind of funny for Dr. Walker to call him out on what he thought he knew, but he didn't really know, it's not even about blaming anyone or anyone on the staff. It's about identifying where improvements need to be made, where there's inefficiencies in the system, and really working across the whole team to figure out the solution to the problem. So
that's right. His response was, I had no idea. When I asked patients, they say I'm fine. And I said, well, let's build on the data. Let's look at how many of your patients have had an A1C in the last year. And so he was shocked at that number. And so I think just getting that information and putting it in front of him allowed him to build protocols and put things in place so that we could move into team-based care, because there's no way one provider can do it all. You need everyone practicing at the top of their licensure to make this work.
Exactly. Perfect example. So, Alicia, let's dive down a little bit deeper on one of the care functions as we talk about some of the resources available, some of those change tactics that Dr. Sessoms alluded to, and, of course, those all-important requirements.
Thanks, Amy. And thank you so much, Angie and Dr. Chan. I think we'll hear from you guys more at the end, but I was laughing, both of you. We're so candid and honest with what you shared, telling us about the gross parts of your office and teasing your providers about how bad they, quote, suck. So it's really fun to be able to learn from you guys, being so open and candid with your experiences. So great to have you on. So we walked through the 5 primary care function, and we have heard some practice examples of their work in these areas. And now, as I said we'll take a deeper dive into the comprehensive primary care function of care management. The purpose is to walk through some of the resources and information available to you to support your care delivery in all of the functions, using care management as an example. So the next slide, we are going to introduce a new resource. Next slide. So the new resource is the CPC Plus Change Package. So Dr. Sessoms mentioned that, and it is available for download on the lower left-hand side of your screen. The change package really outlines each of the drivers and functions as shown in the care delivery diagram that we went over at the very beginning. And it provides related concepts and tactics to support achieving the aims of each. The change package is really a pathway into care delivery and care delivery management of the comprehensive primary care drivers and functions. So now I want to walk you through this care management example so you start to see the format of the change package that's available to you. So on the left-hand side, what you see are the change concepts. Within each of those concepts, there are several tactics, which should pop up on the screen now. We have provided an example of each tactic for each concept on this slide. So let's walk through it. So the first change concept is assigning and adjusting risk status for each patient. One of the tactics associated with that is using a consistent method to assign and adjust risk status for all empaneled patients, with the first step an algorithm and the second being information from the clinical team. So within the change package, what you'll see is that under each of the change concepts, there's several tactics. So that's just one of the examples. As a second change concept, providing longitudinal care management, a tactic is using on-site, non-physician, practice-based, or integrated shared care managers to proactively monitor and coordinate care for the highest risk cohort of patients with assistance from other practice staff as needed. A third change concept is providing episodic care management, including management across transitions and referrals. A tactic to support that, one of the tactics provided under this, is providing care management services to patients with a recent ED visit or hospitalization. And the services around that might include care transition planning and follow-up, and ensuring diagnosis and discharge plans are understood by patients and families. So this is an example of the type of information you'll see. So it starts very broadly by function and driver, drills down into the change concept, and then provides several change tactics for each of those. So this is a new resource available that helps you kind of start to dig into each of these and think about how you might approach them. So on the next slide, we'll get a little bit more specific and talk about the CPC Plus care delivery requirements. So you've seen these before, but we just want to bring these forward to keep reminding you about what's available in terms of resources and to familiarize you with the different layouts. So on the screen, what you'll see on the left-hand side are the Track 1 requirements. So as a reminder, the Track 2 requirements encompass Track 1 requirements and have a couple additional things. So Track 1 requirements risk stratify all empaneled patients, target proactive relationship-based care management, provide short-term care management with medication reconciliation, support patients following an emergency department visit within 1 week of discharge, contact at least 75% of patients hospitalized at target hospitals within 2 business days. If you're a Track 2 practice, additionally, you will use a 2-step risk stratification process that includes care team input and use a plan of care centered on patients' actions and support needs and management of chronic conditions for patients receiving longitudinal care management. So CMS will advance and refine the requirements throughout the course of CPC Plus. Practices will report on their progress in fulfilling these requirements every 4 or 6 months, depending on the measure. Moving on to the roadmap. So the roadmap is a document that should be starting to feel pretty familiar to you. You've seen it in the Phase 1 CPC Plus implementation guide and during the CPC Plus orientation webinar last week. This is the care management function roadmap for the first year of care delivery redesign. And on the screen, we're looking at just the Track 1 requirements right now. The additional Track 2 requirements are on the next slide. As a reminder, in the roadmap, care delivery requirements are noted in light blue. So right now you're looking at the light blue side or the Track 1 requirements. And the high-level changes that may lead to that requirement are in green. The requirements in the roadmap match the requirements shown on the previous slide, but this roadmap is a different view that provides the incremental steps your practice might take to achieve the requirements. The roadmap walks you through the suggested sequencing of high-level changes. For example, before you target care management to patients, as showed in the third row, you will first need to identify those patients you want to target and would benefit most from care management services, shown in green. The Track 2 sequence and requirements are outlined in red, which we'll now look at on the next slide. So you can use these roadmaps to identify your stages of readiness, and you can look to the roadmaps as a guide for pacing your change. Your practice can start at the stage appropriate to its own needs and resources. As a Track 2 example, before you can use a care plan to support the needs in management of chronic conditions, you might want to first identify what care planning tools are available in your EHR and test a strategy for integrating care plan development into patient workflow, and then implement the strategy. By the end of 2017, you should have fulfilled and even moved beyond the care delivery requirements and be ready to advance to the next step of redesign. Now let's hear from Amy and our practices to get the in-practice experience about implementing care management.
Thanks, Alicia. So, Dr. Chan, you already talked to us about how you're providing both longitudinal and episodic care management and a lot of the different factors that went into that. Looking at some of the roadmap targeted areas here, can you tell us a little bit about how your practice is using care plans in your practice? And were you using them before? Are you using them differently now? Maybe speak a little bit to that. I caught you off guard.
You did.
Well, you can even elaborate in talking just more about how overall, in terms of your care management redesign, in addition to what you already described, what are some of the other factors that have changed since when you started in CPC?
Well, our care management team has really expanded over time. And, as I mentioned, because we are a large group, we had the ability to share these resources across the organization. And we started off with a very small, focused group of just care managers. And we were able to identify, as we risk stratified our patients, how many of these individuals we would require across the organization. And so it's just been impressive to see the type of resources that these individuals have been able to bring in that we never identified as physicians, and as clinicians. And so they have social work backgrounds as well as community outreach programs. And by virtue of their extended knowledge, beyond what we learn in medical school, it's just been an incredible experience to have their resources. Our patients are so thankful to have them available and outreaching to them and being in contact with them on a regular basis. They're in contact with our longitudinal patients if diabetics are uncontrolled on a weekly basis to just touch base, and the value in having our patients improve their compliance because of that extended outreach that hasn't directly required clinician care, but just as an extension of us. It's just been an incredible resource, and I cannot talk enough about how thankful I am to have had the opportunity to participate in CPC Classic and to implement this for my patients.
Well, and building on what you were just saying, to address one of the questions that came in, are you providing care management services like this for all your patients or only those that are attributed to CPC?
Across our whole panel of patients. It's impossible to differentiate a CPC patient and a non-CPC patient. And to be honest, from my perspective, it's not how we want to practice medicine. If we want to practice medicine and provide great care to our patients, then we should be providing great care to every patient. And so we have adopted the attitude that whatever services that have been implemented for the office, we've extended to all of our patients.
I think that's a really critical point, because CPC Plus is really about total practice transformation, and that's why there's other payers that are partnering with this program, because we know it takes a significant investment, and you can't change just for one part of your patient population. based on who their payer is, who their health plan is, or how they're paying for those services. So I think that's a really important point to drive home. Angie, do you want to talk a little bit, just to kind of wrap up the care management piece about some additional changes your practice made?
I would kind of jump on with what Dr. Chan said, but also, we're a smaller practice, and so we initially started off just having a care manager who just managed those patients, and then we really quickly saw that that was not working. And so what we did was we retrained staff so that they understand some of those roles and functions and can help jump in with those roles and functions, and it improved our employee satisfaction just tremendously. Because now you have them, and I hate to keep saying practicing to the top of their licensure, but it doesn't take an LPN to do vitals. And I can't imagine if my only job was to do vitals and room a patient. Most of these people go to school because they want to help people, and when you can engage them in the process that you're doing, you're tremendously better off. The patient is better off because they now don't have just the provider looking at them. They have the whole office looking at them. So we really do that from the front all the way to the back. One of the things that we are trying to focus on as we move into Plus is episodic versus longitudinal. And so what we found was with us retraining nurses, there was just some things that those patients needed that we couldn't carve out the time for our employees to do. And so that's the thing that we've added this year is actually having that longitudinal nurse who, once we do our risk stratification, we're identifying whether they're episodic or longitudinal, we're splitting them up. And so I'm ecstatic and can't wait to see the results of this. So,
So Angie, every time you talk about changes that you made in your practice, we heard you talking about adding more staff. A lot of our audience thinks that you must be just drowning under a staff hour debt. How are you funding all this in your practice?
So what happens is you start to change responsibilities. And so where I used to have maybe 4 LPNs working for the provider, now I've changed that to LPNs and a couple of MAs. And so you change the dynamics of who you want to target what. And one of the things that you absolutely hate is sometimes you'll have staff turnover. You'll have a staff member that's been with you for 20 plus years. And, suddenly because of change fatigue or what have you, they just can't do it anymore. And unfortunately, sometimes it's necessary. I would say, don't get discouraged by that. Look at the opportunities in that. We had a little bit of turnover this last year. Well, what it allowed me to do is split up some responsibilities, change the dynamics of my staff, and then instead of adding 2 people where I had 2 people let go, I just added 1. And so, you as the office manager have to look at those numbers and crunch those numbers, because with us being a small town, I cannot hire someone for 4 years and then at the end of this project term their employment. I can't do that.
Right.
So I have to look at what I have existing, make changes to the existing, and then see where I'm lacking.
This has been great. I know there's lots more questions coming in, and the CMS team wants to answer a few questions too. So, Alicia, can you just give everyone a reminder about some of the upcoming events that we want to make sure everyone has on their calendars, and then we'll get to a few more questions.
Absolutely. So just as a quick reminder, we are planning to provide several webinars for our CPC Plus practices. Shown here the proposed schedule for the first quarter. Note the Care Delivery Series webinars are bolded and italicized. So the next one is Care Management on February 2nd. There is another webinar in between there on the portal and CPC Plus Connect. So CMS, I will turn it over to you to answer a couple questions.
Hi there, this is Laura Sessoms. One quick question we've gotten a bunch of is about payment. Obviously, care management work and all the work we're asking practices to do does require payment, and I can certainly speak to the CMS payment. I know that many of the other payers have begun their processes to get payment out to you for the first quarter. Our payment, the process has started, it started a long time ago, but it's in motion as of today. So for practices who were early and got all of their paperwork in on time, that payment is going out now and should you should receive it by the end of the month or late this month. Others for whom paperwork was delayed, the payment is also delayed, but you will get it this quarter, whether February or March.
Hi, this is Gabrielle Schechter. I'm on the CPC Plus team and help with the care delivery work here. So we've gotten a number of questions on practices that are affiliated with each other and whether they can share a PFAC or whether each practice is required to have their own PFAC or Patient and Family Advisory Council. So just want to reiterate what we heard today, that CMS and CPC Plus really thinks that PFAC is a strategy for engaging patients and families and helping understand how the practice works from a patient's perspective and how to enhance the system of care. So much of the feedback, as we've heard today, will be practice location specific, and the greatest value of a PFAC will be if it addresses the specifics of the experience of care at a practice location with those that work and seek care there, right? So each CPC Plus practice, therefore, is required to establish its own PFAC. So, yep.
Another one here is, if you are participating in CPC Plus, can you build a transitional care management code? And the answer to that is yes. So as a part of your care management work for transitions of care, you may build that code assuming you meet those requirements.
I think the team really mentioned this very clearly, but just want to reiterate that CPC Plus is a population-wide transformation model. So all of these changes that we discussed today are really across the population. So we're speaking, this is a multi-payer model. You'll have supports from, part of one of the eligibility for you to be part of the model was that you had supports from multiple payers. So you'll be receiving that support, and therefore, you'll have the support to do this across the patient population, and that's really key to your work.
Can't emphasize that enough, that it's your entire practice population, regardless of whether they are covered by CMS, a payer partner in CPC Plus, an uninsured patient, a Medicaid, covered by Medicaid patient, anybody in your patient population is who this intervention is targeting.
All right. I think that wraps up our presentations for today. I do want to thank everyone for participating in today's learning event. We know you're really busy and appreciate you taking the time to attend. Also, please do remember to take the survey that will follow. Your confidential feedback is very important to us and will help us to improve future learning events. So thank you to all of our presenters today, including our practices. It's really exciting to continue to hear more and more about the work that is going on and will be going on in this initiative.
Ladies and gentlemen, thank you for participating in today's webcast. This concludes the program. You may now disconnect.